any ST elevation is should raise a high index of suspicion for underlying heart disease. Although it can be normal in certain individuals, like young males, which I'll be describing later. And it can be due to other causes such as channelopathies and stress cardiomyopathy and etc. So this is a pictorial description of the ST segment. So the ST segment and the ST interval are not the same. The ST segment begins at the end of the QRS complex, that is the J point, and it ends at the onset of the T wave. So the region of the ECG between the J point to the onset of the T wave is the ST segment. And how do you measure the ST elevation? It is generally the consensus is that you have to compare it with the PR segment or the end of the PR segment. So if the ST is elevated more than 2 millimeters relative to the PR segment, then you say that the ST segment and the elevation of ST is 2 millimeters or 0.2 millivolts. So what are the most important causes of ST elevation? Most importantly, it is a transmural infarction, which we commonly refer as STEMI, or it can be a sequelae of STEMI because of the LV aneurysm. And finally, it can be due to Prince metal angina, which is a reversible cause of ST elevation because of coronary vasospasm. Generally, the ST elevation is transient, and it can be reversible with vasodilator, coronary vasodilator. Relevant to my topic are the non-ischemic causes, which I'll be describing further. The most important cause or the most common cause of ST elevation in the general population is the early repolarization variant, which is generally considered a benign entity. However, in the last couple of decades, ERS has been associated with idiopathic VF and sudden death also, which I'll be describing in detail later. Other causes include acute pericarditis, left bundle branch block, LV hypertrophy, Brugada syndrome, Takotsubo syndrome, hypothermia, which produces the classical Osborne wave, which is nothing but elevation of the J point. Hyperkalemia can also be associated with ST elevation, although it is not a classical finding of hyperkalemia. In hyperkalemia, generally you see peaking and tenting of the T wave, there will be widening of the QRS complex and flattening of the T wave. Although sometimes you can get ST elevation also. So always keep hyperkalemia in your mind when you are interpreting the ECG. Finally, most cardiovascular for any arrhythmia, usually more commonly fibrillation, that can be transient ST elevation, lasting for a few seconds to many minutes, which is not of major significance. So whenever you encounter ST elevation, always look at several features, such as the magnitude of ST elevation. For example, if the ST elevation is more than 5 millimeters, then it is more likely to be ischemic. A patient with ERS, early repolarization syndrome, or with Brugada syndrome, or whether it is pericarditis, generally the ST elevation does not exceed 5 millimeters. So if it is more than 5 millimeters, always think of ischemia. Next, look at the morphology, whether the ST elevation is convex or whether it has a cold appearance, which is very classical of transmural myocardial infarction, but also seen in channelopathies such as Brugada syndrome. However, in most other causes like early repolarization syndrome or acute pericarditis, the ST elevation tends to have a concave appearance, which means concave upwards. Then also look at the distribution of ST elevation. In patients with STEMI, the ST elevation corresponds to the coronary territory. For example, in a patient with anterior MI, the ST elevation will be limited to V1 to the anterior precordial leads. Similarly, a patient with inferior wall MI, again the ST elevation will be limited to the inferior leads, and there will be concomitant reciprocal changes in the opposite leads. So always look at the distribution, don't just look at the ST elevation, also look for reciprocal changes. Then also analyze the QRS segment. QRS width is important. For example, patient might have fascicular blocks, and ST elevation may be secondary to the to the conduction abnormality. So analyzing the QRS width and QRS morphology is also important. Then look for prominent electrical forces, which means measure the QRS amplitude as well. For example, patients with LV hypertrophy due to hypertension or due to hypertrophic cardiomyopathy, they can also exhibit ST elevation, especially in the anterior epicardial leads. And also look at other features. Coming to the next slide, yeah. So this is what I meant by convex versus concave elevation. So what you do is you just draw this for the beginners especially. So just draw a straight line from the J point to the apex of the T wave. If the ST segment is lying below this line, then it means it has a concave morphology. If it is above this line or along this line, then it is convex. So now I'll be going into the causes of ST elevation individually. Although I'll not be going in detail of all the causes, I'll just touch upon the most important causes. So one of the most common mimics of acute coronary syndrome is acute pericarditis. Usually occurs in young or middle-aged individuals, and they typically present with chest pain, which is more of a pleuritic kind of a chest pain, which worsens with inspiration and gets relieved on leaning forward position. So always, when you're interpreting the ECG, always take a proper clinical history as well and examine the patient also. So ECG should never be interpreted out of clinical context. So coming to pericarditis, the most common cause of pericarditis, acute pericarditis, is post-viral pericarditis, which is usually diffuse pericarditis, and this is a situation in which you get the classical ECG findings. A patient with localized pericarditis generally may not manifest all the ECG findings. So this is a classical ECG of a patient with pericarditis. Generally, there are diffuse ST elevations from involving the anterior, inferior, and lateral leads, except for AVR and lead B1, which are generally considered to be endothelial leads. The other leads are epicardial leads. So except for AVR and AVL, there will be diffuse ST elevation, and importantly, there will also be PR segment depression, which is a analog of atrial involvement. So another important thing is always look at the T wave. The T wave is generally upright when the ST is elevated in a patient of pericarditis, which is unlike a patient with ACS. Kodik et al. Described pericarditis as having 4 different stages based on the ECG findings. The stage 1, it lasts for a few days to a couple of weeks, and it is accompanied by the classical ECG findings such as diffuse ST elevation and PR segment depression. Stage 2 follows stage 1. It can last for a few days to few weeks, during which the ST segment elevation tends to normalize. However, the T wave still remains upright. Next, stage 3 occurs after 2 to 3 weeks and can last several weeks, in which the T wave starts inverting. But T wave inversion occurs only after normalization of the ST elevation. That's a very important point. Then the final stage is stage 4, which is normalization of the T wave inversions. So how do you differentiate pericarditis from ST elevation MI? The ST elevation in pericarditis is concave as opposed to convex in patients with STEMI. Then coming to the distribution, The ST elevation is diffuse in patients with acute pericarditis, whereas it is territorial in patients with MI. There will be PR segment depression in patients with pericarditis, which is not seen in patients with MI. However, as the ECG changes evolve, they tend to develop Q waves. Finally, T wave inversion in patients with pericarditis occurs only after normalization of the ST segment, which is unlike the STEMI. So the next important topic is Brugada syndrome, which is also associated with ST segment elevation and can also cause clinical confusion, diagnostic confusion. Especially, it can mimic anteroseptal myocardial infarction or RV infarction sometimes. So I'll be discussing in detail about Brugada syndrome, and this is something which is very close to my heart also, especially being an electrophysiologist. So please bear with me. So what is Brugada syndrome? It is inherited channelopathy, most commonly due to loss of function mutations in the SCN5A gene, which encodes the sodium channel and which is responsible for the phase 0 of the action potential, that is the depolarization phase. So classically it presents with incomplete RBB pattern with ST segment coving in the right precordial leads, classically in leads V1 and V2. Most important thing is the ECG changes are dynamic. A patient may have ST elevation one day, the next day the ST elevation will regress. A patient develops fever, suddenly the ST increases, ST elevation increases, and upon subsidence of the fever, it will regress. It is dynamic. There is day-to-day diurnal variation in the ST segment elevation. So that is the importance of using provocative maneuvers in these patients. These patients generally have structurally normal hearts. If they have underlying heart disease, then you have to suspect arrhythmogenic right ventricular cardiomyopathy instead of Brugada syndrome. Most commonly involves young and middle-aged males. These patients are at risk of ventricular fibrillation and sudden cardiac death. Usually occurs at rest or during sleep. Nocturnal deaths are very classical of Brugada syndrome and almost never occurs with X-rays. You have to remember that. The condition was first described by the Brugada brothers in 92. The most common mutation, which is seen in 25% of the cases, involves the SCN5A, which is the sodium channel. Other channels also are implicated, such as the calcium channels, which is seen in the mutation is seen in about 7% of the cases, and then even the transient outward potassium channel. For example, if there is a gain of function mutation of the ITO channel, then that can also resemble the Brugada syndrome. So this is a classical ECG of patients with Brugada syndrome. You can see the leads V1 and V2. There's an incomplete RBB pattern, and there is ST segment elevation with a coved appearance. And most importantly, the elevation of ST begins at the peak of the R prime. Unlike a patient with anteroseptal MI or a proximal LED occlusion, in which you can also get right bundle branch block with ST elevation. In those patients, there may be a Q wave, and the ST segment elevation does not begin at the peak of the R prime. It begins generally at the J point, which is usually isoelectric. Then the T wave tends to be inverted in most patients in the anterior precordial leads V1 to V3. So what is the pathophysiologic or the ionic basis of these changes? So based on the classical experiments by Anselevich and co-workers, the most accepted hypothesis or the pathophysiological basis of Brugada syndrome is that there is a difference in the notch in the epicardial action potential versus the endocardial action potential. This occurs because the density of the transient outward potassium channels is higher in the epicardium compared to the endocardium. So in a patient who has a sodium channel or a calcium channel mutation in which the depolarization is blunted, the notch, which is the transient outward potassium channel mediated notch tends to be deeper, and this is the reason why at the end of the depolarization, that is the phase 1 of the action potential, you get a voltage gradient, and on the surface ECG it is manifested by a J wave. So what happens whenever there is electrical gradient? It causes heterogeneity of repolarization on the epicardium, and that is because of this heterogeneity in repolarization or dispersion of repolarization, there is phase 2 reentry occurring in the epicardium, which can initiate an extrasystole, and that can cause a R on T phenomenon and induce a ventricular fibrillation. So classically, these patients have polymorphic VT or ventricular fibrillation. So I'll present two interesting cases of Brugada syndrome which we encountered at our institute. So both are very memorable cases, and I would definitely like to share that experience. So case 1 was a 45-year-old male. He was previously diagnosed with Brugada syndrome in almost 10 years back, and then he had recurrent syncope, which was not documented. He underwent a ICD implantation 7 years back. Then he presented to us with recurrent ICD shocks. This case happened sometime in 2016. His underlying ventricular function was normal. So when we analyzed the EGMs in the ICD, we noted that patient had almost 10 appropriate shocks for VF in the space of almost 10 minutes. So the second figure here shows the intracardiac EGM recorded in the ICD. So there is a regular rhythm going on, ventricular rhythm, which is probably sinus rhythm, and then there is a ventricular extrasystole (PVC) on which causes the R on T phenomenon and initiates a ventricular fibrillation. So this patient had almost 10 shocks in a space of around almost 15 minutes, 15 to 20 minutes. So how do you manage such a patient? The first thing is you always deactivate the ICD therapy, because ICD shocks are very painful. So you cannot allow the patient to get recurrent shocks, especially when he is in ICU setting. Second thing is you intubate the patient, sedate the patient completely. Then what are the drugs which are effective in patients with Brugada syndrome? Can we use beta blockers? Can we use calcium channel blockers or lignocaine, amiodarone? So the most effective and well-studied drug is isoprenaline, which is usually given in a bolus of 1 to 2 milligrams, followed by 0.1 to 0.3 milligram per minute continuous infusion. There are some studies which show that quinidine is very helpful in these patients. Quinidine is a selective blocker. It's a selective blocker of transient outward potassium channel. So by blocking the potassium current in these patients, it reduces the voltage gradient during the phase 1 of the action potential and reduces the probability of phase 2 reentry. However, quinidine is not available in India. So what we did was we used quinine, which is an anti-malarial drug. We used at a dosage of 300 milligram TDS, and almost magically, like within 24 to 48 hours, all the VT episodes were suppressed. So this was the ECG. You can look at the ST morphology in leads V1 to V3. There is significant elevation at presentation. With isoproteinol infusion, the ST elevation has come down, and then on follow-up, this ECG was done at 2 weeks after discharge. So you can see that almost the ST segment has returned to its baseline. So this was a very interesting finding. Quinine is not a well-studied or well-accepted medication in patients with Brugada syndrome, and we published this case in heart rhythm case reports. So second case is also equally memorable case. So this is a case of a 54-year-old gentleman who was referred to us because of a history of aborted cardiac arrest. He was advised ICD, but because of financial concerns, it could not be done. His LV function was normal. He did not have any other illnesses and was not taking any medication. So what do we do? Patient doesn't have finances for ICD. So this was the ECG at presentation. You can see that in lead V1 there is a incomplete RBB pattern with ST segment elevation. So V2 and V3 are showing more of a saddleback type of ST elevation. I didn't mention earlier that Brugada syndrome can be classified into 3 types based on the ST segment morphology. Type 1 is where there is a classical coving ST elevation. Type 2, you get a saddleback ST elevation of more than 1 millimeters. And then type 3 is again a saddleback elevation but less than 1 millimeter. So in the type 1 pattern is diagnostic of Brugada syndrome, whereas type 2 and type 3, you need provocative maneuvers to unmask the Brugada ECG pattern. So what we did was we took up the patient for catheter ablation. We did a electroanatomic map of the right ventricular outflow tract. So this map is, the images are shown in REO and LEO. So both the endocardial and the epicardial maps are overlapped. So in the epicardium, on the anterior RVOT wall, free wall, we could find localized areas of low amplitude fractionated signals and also late potentials. And what we did was we updated there with the irrigation catheter, and then I'll just show you the signals. Yeah, this one of the areas. This you can see this arrow pointing at late potential. It's a fractionated signal, and it's a low amplitude signal, and it is extending beyond the QRS complex. So we ablated similar signals from the RVOT. And then this was the ECG. You can look at the ECG pre-RFA, especially leads V1, V2. There is significant elevation, almost 4 to 5 millimeters. However, post-RFA, the ST segment has come down, although it's not yet fully disappeared. So this patient is doing well. It's almost 1 year now since ablation. He has never had a recurrence of syncope or any other symptom. So this one study from the Anselevich group, where they have shown that patients before epicardial ablation and post epicardial ablation, the notch tends to be greater prior to ablation. So this is, they have used pinacidil and ajmalin to block the sodium and calcium channels. So upon blocking that, because of the ITO channels, there is a prominent notch in the epicardium, whereas the endocardium doesn't exhibit a significant notch because these ITO channels are localized more to the epicardium compared to the endocardium. And post ablation, you can see that there is no notch even in the epicardium also. So next syndrome which I'll be discussing is the early repolarization syndrome. Until a couple of decades back, it was considered to be a uniformly benign entity. It is very commonly seen, especially in young males, especially in blacks, and usually it is not of much significance. However, in the last couple of decades, there are several reports which have shown that early repolarization finding on the ECG is more common in patients who have survived a cardiac arrest or idiopathic VF. So this is similar to the Brugada syndrome. So Brugada syndrome and early repolarization syndrome, they are clubbed together nowadays, and they are referred as J-wave syndromes because there is elevation of the J-wave and also the ST segment with upper concavity and prominent tall T waves in at least 2 contiguous leads. Brugada syndrome, it's generally the anterior epicardial leads which are affected because of the density of the channels in the RVOT. Whereas in the early repolarization syndrome, it's either the inferior wall or the lateral wall of the left ventricle which is involved. So this is a very typical ECG of a patient with early repolarization. You can see that there is J point elevation, especially in leads 2, 3 AVF and also in the lateral leads V4 to V6. The HT segment has a concave appearance, and the T waves are very prominent, especially in the precaudal leads. So ERS is generally classified into three types. In ERS subtype 1, the J point elevation usually is limited to the mid precaudal leads, V2 to V4, and it is seen in healthy young adults, young males, and those with black black rays, and usually has a good and favorable prognosis. Whereas in patients with ERS2 type 2, the ST elevation and J point elevation is it involves the inferior and the lateral leads, and there is a moderate risk of adverse cardiac events, specifically the risk of VF. Then the most severe form is the ERS type 3, in which there is global J point elevation, which is associated with the highest risk of VF, almost to the tune of 15 to 20%. So the prevalence it varies from 1 to 9%, depending on the various studies. Depends on the age as well, as I already mentioned. It's more common among blacks and young males, and depends on the criterion which is used for measuring the J wave elevation. Usually, 1 millimeter is taken as significant, that is 0.1 millivolts. So, based on several studies, early repolarization is more commonly associated with patients with idiopathic VF compared to control subjects. That is 31 to versus 5% in one of the studies by Hasigare and his group. So the presence of ER pattern, J point elevation, especially in the inferior leads, or if it is present globally, then the risk of VF is high to the tune of 5 to 10 times than the general population. So this is one representative ECG of a patient who had idiopathic VF, and you can see that there is significant J point elevation, both slurring as well as notching of the J point. The first figure shows slurring of the terminal part of the QRS complex. In the second portion, there is a notching of the QRS complex. So this was one of the important papers which was published from the Bordeaux group by Hasigare et al., in which they found that in patients with so-called idiopathic VF, many of these patients also had early repolarization changes, that is J point elevation, and the J point elevation was dynamic, and it was highest just prior to onset of VF. So as of now, the consensus is that early repolarization syndrome is generally a benign entity if it is not diffuse, if it is not global, and a patient who has global ST elevation and has symptoms such as syncope, then definitely such a patient should be considered for a ICD implantation. The next syndrome which I'll discuss is the Takotsubo cardiomyopathy, which is again a very close mimic of STEMI. So these patients again they present with chest pain, LV dysfunction, heart failure. So it causes a lot of diagnostic dilemma in the ER. So generally, it is usually seen in post-menopausal women. It is usually triggered by physical or emotional stimuli. Classically presents with basal hyperkinesis with apical ballooning. And the pathophysiology, it implicates the sympathetic nervous system. The emotional stimuli or the physical stimuli, it triggers the sympathetic, it causes sympathetic overactivity, and then causes a form of severe hyperkinesis and apical ballooning. So all types of STT changes are seen in patients with Takotsubo cardiomyopathy. Generally, it has a good prognosis. However, if a patient has prolonged QT, then they are also prone for sudden cardiac death. So this one ECG in which patient with chest pain showed some ST elevation in leads V2 to V5 and even V6 also. Eventually, the patient underwent coronary angiogram, which showed normal coronaries, and echo and LV angiogram showed apical ballooning and basal hyperkinesis. So I'll just show one case which we encountered almost 5 years back. So this is a young lady, 31-year-old lady who had undergone a pacemaker implantation for congenital CHP. She presented to us with recurrent episodes of syncope after the death of her father, and her echo was normal with normal biventricular function. So out of the three ECGs, the topmost panel shows the ECG at presentation, in which she had runs of torsades and occasional pace beats in between. Then what we did was we loaded her with lithium and increased the pacing rate to 100 per minute, so that the QT gets shortened. The middle figure shows the baseline ECG after giving magnesium. The runs of electricity have been suppressed. However, you can see that the QT interval is significantly prolonged, and there are some ST changes as well. And the final figure shows the ECG on follow-up after resolution of the cardiomyopathy. The QTC has returned to normal. It's almost 440 milliseconds, whereas here in the at presentation the QTC was more than 600 milliseconds. It's more than three large vessels. So this was the LV angiogram. We showed basal hyperkinesis along with apical ballooning. So we reported this case in JECG, and this is one of the rare cases in which we have documented torsades as a consequence of Takotsubo syndrome. So to conclude, ST elevation is an important sign of underlying disease, most commonly transmural infarction. So making a proper diagnosis is of paramount importance, since the time available for salvaging the myocardium is quite less. So, however, making the appropriate diagnosis is of significant importance. We cannot thrombolize a patient who doesn't have MI but wrongly diagnosed as STEMI. So, we should carefully analyze the ST segment with respect to the morphology, see whether the ST elevation is concave or convex, look at the distribution. Does it correspond to a particular coronary territory? Look at the QRS width. Most patients with LBB will have some degree of ST changes. So if there is bundle branch block, don't rush for revascularization. Apply the Zarbosa criteria, where concordant ST segment elevation is suggestive of acute MI. However, if there is a discordant ST elevation or ST depression, it is usually not much of clinical significance. Also look at the QRS amplitude, because all the changes may be because of LV hypertrophy. Finally, always interpret the ECG in the setting of clinical history and examination. Never interpret any ECG in isolation. Thank you for your kind attention.
Thank you, Dr. Bharat, for such a elaborate presentation. We'll just go to a few poll questions to make the session more interesting. Sir, you can move to the next poll question, and I then open the poll.
Okay. I got 3 questions.
Yeah. So this is the first poll question. I'll read it out, sir.
Yeah,
all are
sure.
true about Brugada syndrome except A, more common in males, B, ECG changes are dynamic, C, classically presents with monomorphic VT, and D, catheter ablation is a treatment option. This poll is sir has already explained. We'll just see how it goes. So I'll open the poll now. Yeah. So here it goes. This poll is for a 1 minute. I think a little bit more time we have given. It's 4 seconds left, sir, and is about to close the poll. Yeah. Yeah. So I saw the poll results, sir. Yeah. You can see, sir.
Yeah.
So majority have told 167 out of 468 that it classically presents with monomorphic VT. That is a false statement.
Correct. Yeah.
Say correct statement.
It's a knowledgeable audience.
Very nice. So we'll take next question. We'll go to next question, sir.
Yeah.
So which of the following is true about early repolarization syndrome? A, more common in young males. B, not associated with sudden cardiac death. C, early repolarization syndrome type 3, that is global ST elevation, has a worse prognosis. Again, based on certain topics, I'll start the poll. Yeah, now.
Doctor,
Yes, sir.
it should be, I mean, the question you'll have to slightly modify it. Which of the following is not true?
Oh, so sorry, sir. Anyway, you can explain it, sir. You can explain it. Not a problem. You can tell both the.
Out of the 3 options, 2 are correct and 1 is incorrect. So you have to select the incorrect option.
Oh no, I think already people have more than 50%. So it's not a problem.
Not enough to recognize.
No problem, sir. You can explain anytime. Not a problem. Just for a good interaction. This. Around 175 people have told that early repolarization type 3 has a worse prognosis. Sir, you are not audible. You're mute, sir. You're mute. You're mute, sir. It's going mute. Yeah.
Okay. Yeah, I think most people have created type C, which is true. Yeah, type C has a worse prognosis.
Yeah.
Only type A is also true. It is more common in young males. Long answer, I mean, not associated with the DD. It is a false statement.
We'll take the third question, sir. So the third question is, all of the following can be associated with ST elevation except A, ventricular angina, B, Brugada syndrome, C, hyperthermia, and D, pulmonary embolism. So I'll be starting the poll now. Yeah. Yeah. So you can see the answer, sir. No, 197 have told hyperthermia and 131 have told pulmonary embolism. I think this is one question where almost we got equal balance, almost equal balance.
Pulmonary embolism can be associated with ST elevation, especially in the right-sided precaudal leads. Hypothermia is associated with J-point elevation, which is the off-born wave. Hypothermia. The correct answer is hypothermia.
So we'll take few questions, sir, before we conclude this session.
Yeah, sure.
Deepak, kindly don't leave. We have another session by Dr. Nitin Kansal on ECG localization of MI. Just to Deepak, can we take few questions?
Yes. We'll take a couple of questions. So, sir, one I will just read it for you. One is like, how do you determine if the post cardioversion ST elevation is significant and suggests MI?
Yeah, generally there will be a resolution of ST segment elevation. If the resolution is more than 50%, then I think it's successful. And then you have to always correlate with patient symptoms as well. So a patient who had severe rest angina, the chest pain subsides, then again it's a marker of successful reperfusion. And then today, in the era of primary PCI, I would always say that primary PCI is obviously the treatment of choice. But then again, because of the COVID situation, thrombolysis again has regained some of its lost sheen. So I would suggest that patient symptoms, resolution of patient symptoms, as well as reduction in ST elevation by at least 50% would be reliable markers. Previously, like we used to say that EIVR, that is accelerated idioventricular rhythm, is also a marker of successful reperfusion, but there are studies which point contrary to it also. So that is a doubtful marker.
Okay.
There is one good
question,
sir. Yeah.
Yeah. So another is like, can you please? Sorry, not this one. How do you manage young patients with ERP?
Young patients with early repolarization?
Yeah. Yes.
Okay. Yeah, it all depends on the patient symptoms. If a patient comes with history of syncope or aborted cardiac arrest, then obviously you'll have to be more aggressive in managing the patient. If a patient has only syncope, then prolonged monitoring with ambulatory ECG, either for 24 hours initially and then for 7 days or for 30 days as necessary, you can do. It can be performed, and then also try to rule out other causes of syncope. For example, patient may simply have neurocardiogenic syncope. So tilt table test also will be useful in such patients. And then it's always it's always useful if you can correlate the rhythm at the time of symptoms. So again, it's a very difficult task. It will require prolonged monitoring in such patients. Most of the published studies, they had in-hospital VFs. So that is the reason they could document the J-point elevation, which was progressively increasing, and then suddenly it induced ventricular fibrillation because of phase 2 re-entry mediated ventricular extrasystole. So you should be fortunate also sometimes to document such a correlation. However, with respect to EP study, in patients with Brugada syndrome as well as in patients with ERS, EP study does not have a significant role in risk stratification. That is very important. unlike other patients, like patients with scar BT due to coronary artery disease, or patients with dilated cardiomyopathy, or patients with bradyarrhythmias, there is definitely a role of EP study. But in patients with ERS, patients with Brugada, EP study is unlikely to be helpful.
Thank you so much, sir. I think in view of paucity of time, we'll move on to the next session. Sir, if it is okay, in the end, if we have time, we'll take more questions. Or
Yeah,
sure. Deepak will move on to the next session. The next session will be by Dr. Nitin Kansal. Sir is currently working as a director of electrophysiology and head in the Santolba Hospital, Jaipur. I'll hand over the session to sir, and he'll take over as the presenter of the next session.
Yes, Dr. Nitin, we are able to view your screen. Okay, your audio is on. Dr. Nitin, you are not audible.
Sir, I think you're mute, sir. Dr. Nitin. Yeah.
No, doctor.
Dr. Nitin, sir, you're not audible, sir. Sir, not audible, sir.
Dr. Nitin, can you check the audio of your system? Is it on mute? Of your laptop audio?
Deepak sir is checking 1 minute. No, sir. Sir, your audio is on mute, sir. Deepak?
Yes.
Just 1 minute, sir is trying. Just give it.
Yeah.
Is it coming, sir? I know it's not audible. I think no, sir. Oh, the unmute system is down, sir. No, sir, you're on mute. Yeah, now mute, sir. No, unmute, sir. Just unmute, sir. It feels like your voice is coming from far, but we are not able to hear you here, sir. Just 1 second, sir. I'll tell Deepak to call you, sir. Deepak, can you help just sir?
Yeah. Yes, I'll do that.
Meanwhile, in last when the sir is sorting out, Dr. Bharat, can we take a few questions?
Yeah, Dr. Sudhakar.
Yeah. Sorry for the inconvenience, technical issue. We'll just take some few more questions before we move on to the next session. Yeah. So there is one more question. How, like post CPR, how good do you take the ST elevation? Like, when do you tell post CPR ST elevation is significant or?
Yeah, usually it is not available fine because the rhythm is unstable. Most of the times, patient tends to have idioventricular rhythm many of the times. So it's very difficult to tell. Not just after CPR, even immediately after ablation also. For example, a patient with WPW, they tend to have memory T waves. So it is never a reliable thing. You'll have to just observe the patient, and then if a patient has survived a cardiac arrest, then definitely you should go ahead with a coronary angiogram irrespective of ST changes. One point is like the ST changes are persistent, and if it is classical, if it corresponds to a coronary territory, then obviously you are justified in saying that the ST segment, ST elevation is because of a ACS. But then I think in all patients who have survived a cardiac arrest, we should do a coronary angiogram.
Okay. So there is one more question: how to diagnose MI in early repolarization syndrome?
I think you have to look at the morpho.
Hello.
Hello.
Yeah, we have got Dr. Nitin.
Okay. Sir, I'll take the question in the end, sir, because we are running little short of time, sir. If you don't mind, sir. Oh, okay. Thank you, sir.
Okay, Sudhakar,
Yes, sir.
can you hear me now?
Yes, sir. Yes, sir. Just little bit
Yeah,
more
sure.
louder. Yes, sir. Yes, sir. Thank you, sir.
Okay. So, thank you for inviting me for presenting this session from the Medtronic side. And Sudhakar, you have been the person who has actually been able to make all this possible. So I'm Dr. Nitin Kansal. I'm presently in Jaipur at Central Pathology Memorial Hospital. And the topic today is ECG localization of culprit vessel in case of a myocardial infarction. So what you can see is there is an ECG present here, and there is a coronary vasculature which is seen here with RCA, LCX, and Leftman and LED. And we basically have to decide which artery is involved in this. And I hope that by the end of this presentation, we'll be able to localize which artery is involved. Okay, so this is not moving also. Okay, so inspiration for this presentation is basically from this book by Luna Kansal. This is a very nice book which is actually on electrocardiography of ischemic heart disease itself. And then Dr. S.K. Dwivedi, professor at KGME, has also had given me a few of his slides. So before we move on to what is ST segment elevation is what is important to know. So the threshold values for ST segment changes which should be considered as significant is this has been taken from the JAC 2009, where they have given the guidelines and recommendations for all the ECG changes. So for men 40 years of age and older, the threshold value for abnormal J point elevation should be 0.2 millivolts in lead V2 and V3 and 0.1 millivolts, that means 1 millimeter in all other leads. For men less than 40 years of age, the threshold value for abnormal J point elevation in V2, V3 is 0.25, that means 2.5 millimeters. So there is a small difference between the age less than 40 and more than 40, what you should be considering as significant ST changes. For women, the threshold value for J point elevation should be 1.5 millimeter in V2 and V3 and greater than 0.1 millivolt in other leads. If you are looking at V3 and V4R leads, it should be 0.5 millimeter ST elevation. The posterior leads V7 to V9 also it should be 0.05 millivolts. And for all the people, the J point should be 0.05 millivolts in leads V2 and V3. So what do you consider as typical ST elevation MI for ST elevation MI? So you should have a new occurrence of ST segment elevation more than 2 millimeters, at 60 milliseconds after the J point in V2 and V3, and more than 1 millimeter in other leads. Now, these should be present in at least 2 contiguous leads, and they should be associated with evidence of acute ischemia. That means you should have a clinical setting of chest pain or equivalent. Most of the times you would not have cardiac markers at hand at that point of time. So the STT changes with clinical settings is what you should always look at. And if possible, you should always compare it with previous ECGs. Now, what causes ST elevation? So what you should see is that the electrical activity is only present in normal tissue and not in necrotic tissue. So when there is a normal tissue present, there is a tissue activation potential which is there both for the endocardium and the epicardium, and they basically cancel each other, and therefore you do not have any ST elevation. As the tissue starts getting ischemic from the endocardium to epicardium, the cancelled area gradually becomes less, and therefore in subendocardial region, ischemia, you actually have ST depression, whereas in transmural ischemia, as the ischemia increases, you start having ST elevation. Till you have ST elevation, this is a reversible ischemia, and if you take care of it, the patient would actually have minimal damage to the myocardium. But once the tissue is necrotic, you have Q wave and T wave inversions, and this is the time when the tissue has already gone for an irreversible damage. What is the pathophysiology of ST elevation? This is important because this helps you in identifying the vector in which direction you would actually have ST elevations. So the two theories are that it can occur because of diacyclic injury current, which leads to a primary T2 segment depression. But since we look at TP segment as the baseline, you would have a compensatory ST elevation. Similarly, the systolic injury current would produce a primary ST elevation, and both these are actually considered to be responsible for ST elevation in patients. Now, this is another slide from the bone walls. What you can see is in a subendocardial ischemia, the direction of the ischemic vector is actually away from the surface ECG leads, and therefore you have ST depression. Whereas when there is a transmural infarction, the injury current vector actually is moving away towards the surface ECG, and therefore you have ST elevation. So if you will have an ST elevation MI only if you are having a transmural ischemia. In subendocardial ischemia, you will only have ST depression. Now, what is important is when you do evaluation of, and I don't know why these slides are moving too fast, but anyways, we always look at one second. Yeah. So we always look at the walls which are involved in echo, and you should always have an idea as to which wall you are actually looking at when you're doing a echo in specific views. So what you can see is in parasternal long axis view, you're actually looking at posterior lateral wall, so 4 and 10, and the septum and proseptum. Whereas in apical 4-chamber view, what we are looking at is anterior wall and the septum, and in apical 2-chamber view, you are actually looking at the anterior wall and the inferior wall. So you should be clear as to what exactly you are looking at, and this is actually depicted even in the bull's-eye map, where you can actually identify which all areas are being supplied by specific arteries. So you can see LED supplies the anteroseptum and anterior wall. The RC supplies the infroseptum and the inferior wall, and LCX supplies both the inferior wall, posterior wall, and the infrolateral area. Now, this image is important because this actually shows you that heart is a 3D structure, and you have to look at ECG in a 3D way. You have to look at the vector, whether it is pointing downwards, in which case you will have ST elevations in lead 2, 3, and AVF. If it is directing upwards, so clearly you will have ST elevations in lead AVL and to some extent in AVR. And if it is pointing forwards, that means towards the chest leads, then you will have it as ST elevation V4, V1 and V2, and in anterolateral area you will be having ST elevations in the lateral leads. So all these things actually help you in finding out which leads should have ST elevation when you are thinking of vector cardiography for ST elevation. So first, let us now start with ECG changes that would help you in identifying specific locations of occlusions. So left main, the most ominous one, the first. So the LMC occlusion, what happens is there is a diffuse subendocardial ischemia in the whole of the left ventricle almost, and this leads to a vector of injury which moves from apex towards the base, from forwards to backwards, and from left to right. So what you can see is, since it is from left to right, you will have an ST elevation in AVR. Since it is more forwards, from forwards to backwards, that means it's pointing towards the back, you will have ST depression in all the chest leads. And since it is directed towards the AVR, you will have ST depression in all the other limb leads also. So you will classically have ST elevation in AVR. You can have ST elevation in V1. It might not be present, but you'll have ST depressions significantly present in 2, 3 AVF, 1 AVL, and V2 to V6, with maximum ST depressions being there in V5, V6. So if you have such a presentation, this is almost pathognomonic of left main occlusion, and you should always be wary of this particular kind of an ECG presentation. So what is the predictive value of ST elevation in AVR? If you have an ST elevation in AVR more than 1 millimeter, it identifies a proximal LAD or left main or a severe triple vessel disease. ST elevation in AVR more than 1 millimeter, you have more chances of having a patient for CABG. And if AVR ST elevation is more than V1 ST elevation, differentiates between LMC occlusion versus a proximal LAD occlusion. ST elevation in AVR almost always is rules out left main stenosis. So AVR ST elevation is very important. You should always look at AVR whenever you have an ECG for interpretation for the location of an MI. Now let us move on to anterior MI and LAD with various levels of occlusion. The first one is proximal LAD occlusion, that is, it is prior to S1 and B1. This is a very large area which is being supplied by the LAD. So you have a part of infroseptum, anteroseptum, anterior wall, and lateral wall, both apex, mid, and lateral area, which is involved. So this kind of ischemic myocardium leads to a vector which is directed upwards, to the right, and forwards. Since it is directed forwards, you have V1, V2, V3, and V4 which shows ST elevation. Since it is directed upwards, you have an ST elevation in AVR and 1 in AVL also. But you have an ST depression in 2, 3, and AVF. You may also have ST depressions in V4, V5, and V6. So this is an ECG for representation of proximal LAD occlusion. What you can see is there is an ST elevation in V2, V3 up to V5. There is an ST elevation in 1 in AVL with ST depression in 2, 3, and AVF. So this is more likely having a proximal LAD occlusion. Another parameter which usually tells you that it is a proximal LAD occlusion is if you have a QRBBB present with ST elevations in anterior leads, then this also actually points towards proximal LAD occlusion. In comparison to that, when we look at distal LAD occlusion, where you have occlusion after S1 and B1 both, the area of jeopardy is much less. You have only apical and mid area of anteroseptum and anterior wall which is involved. Most of the lateral wall which is supplied by the diagonal branches and the basal septal area which is supplied by the septal branch is already spared. So you would have an area of Jeopardy which is usually U-shaped, and it does not have any component which is moving forwards and upwards. So the injury vector now is directed downwards and to the left. This leads to ST segment elevation from V2 to V6 with ST elevation in or isoelectric ST in leads 2, 3 and AVF. You would have an ST depression in one AVL because the injury vector is now directing downwards. So this is what has been represented here. If you have an ST elevation in inferior leads in addition to the ST elevation in anterior leads, then most likely you are dealing with a distal LAD occlusion versus ST elevation in one AVL with ST elevation in the anterior leads, then you are most likely dealing with proximal LAD occlusion. LAD occlusion post S1, pre-D1, what is happening is your basal septal area is now spared. Rest of it is almost the same as the proximal LAD occlusion. But since the basal septal area is spared, your vector actually is now not directed anteriorly towards V1. Actually, it is directed away from V1, and therefore you have a vector which is directed anteriorly, superiorly, and to the left, and therefore you have ST elevations in one AVL, V2 to V6, but you have ST depressions in 2, 3, and AVF. What is important is that V1 ST elevation won't be there if your basal septal area is spared. If you have occlusion if you have an occlusion which is present post V1 but pre-S1, that means your septal is involved but the anterolateral area is not involved. In this case, you will have an ST elevation in V1, and there can be ST elevations in 2, 3, and AVF also. So what is important to understand is, if septal is involved, you will have ST elevations in anterior leads, including lead V1, whereas if septal is not involved, the lead V1 might not show you ST elevation. If the D1 is involved, then you will have ST depressions in 2, 3, and AVF, that means inferior leads. But if your diagonal is not involved, you might have ST elevations or isoelectric ST in 2, 3 AVF. So now we are going only for septal occlusion. Here you can clearly see it's a very small area of basal septal area which is involved, and therefore you would have an ST elevation in V1, V2 with even ST depressions in the lateral leads and superior leads. So now we would go for some algorithms for LAD occlusion which help in localizing what is the level of LAD occlusion. The first algorithm actually starts with, if you have ST elevation in the anterior leads, then you are suspecting LAD occlusion. Always check ST segment in 2, 3, and AVF. If the sum of ST depression in 3 and AVF is more than 2.5 millimeters, ST depression, you are dealing with occlusion proximal to D1. If you have ST elevations in 2, 3, and AVF, you are dealing with an occlusion distal to D1. Clear? In either case, next you are going to look at sum of ST elevation in AVR, V1, and ST depression in V6, and if that is more than 0, or there is a presence of new onset right bundle branch block, QRBD, that is what we most of the times call, then you are dealing with occlusion proximal to H1. So look at 2, 3, and AVF. If it is ST depressed, but there is an ST elevation in AVR and V1 or ST depression in V6, then you are dealing with a pre-S1, pre-D1 occlusion. That means proximal LAD occlusion. If you have an ST elevation in 2, 3, and AVF and you do not have ST elevation in AVR or V1 or ST depression in V6, you're dealing with an occlusion distal to V1 and S1 both. And the combination of these would help you in identifying whether it is pre-S1, post-V1 or pre-V1 post S1. Same thing has been described in this as a stepwise approach, but it's more or less the same thing. If you have ST depressions, you're dealing with proximal D1. If the ST depressions are less than 0.5 and more than 0.5 but less than 2.5, it does not help you in any ways. If there is an ST elevation, you're dealing with distal to D1 and S1. Once that step is over, you look at VR, V1 and V6. If the sum is more than 0, you're dealing with proximal to S1, otherwise it is distal to S1. This one is a little simplified form where you can just diagnose whether it is proximal or distal. You do not diagnose whether it is pre-S1, D1 or what. Here you look at ST segment elevation, right bundle branch block, you are dealing with proximal LAD occlusion. ST elevation is more than 2.5, right bundle branch block, it is a proximal LAD occlusion. If there is ST segment depression in 2, 3 and AVF, again you are dealing with proximal LAD occlusion. But if there is an ST depression less than 1 millimeter or there is an ST elevation in 2, 3 and AVF, you are dealing with distal LAD occlusion. This should actually suffice in most of the cases because most of the times you would be interested in finding out whether it is a proximal LAD or a distal LAD occlusion. Next, we move on to inferior volemi, where we have to differentiate between an RCA occlusion or an LCX occlusion. You can clearly see when you have an RCA occlusion, the direction of the vector is actually towards right and downwards. And in LCX occlusion, it is to the left and downwards. So in this case, you will have ST elevation in lead 3, which is more than lead 2, with ST depressions in the opposite leads, that means 1 and AVL. Whereas in LCX occlusion, the lead 2 ST elevation will be more than lead 3. I hope that is clear. In addition, if you have conduction abnormalities or there is a sign of right ventricular infarction, that means which is something which I'll be dealing a little more later on, then you're dealing with an RCA occlusion. If you have signs of lateral infarction, that means ST elevation in lateral leads 1 and AVL or V5, V6, most likely you're dealing with an LCX occlusion, although in large superdominant RCAs, you can still have ST elevations in lateral leads. So this is one ECG where you can clearly see there is an ST elevation in lead 3, which is more than lead 2. There is ST depressions in 1 and AVL, and there is a conduction abnormality going on. This is a group beating going on. So this is most likely a Wenkeback or type 2 block, which is occurring in this patient with inferior volemi. So this is clearly an RCA occlusion, but what you can see is even the lateral leads are showing ST elevation. So most likely this patient has a superdominant RCA, which is causing the ST elevation in the lateral leads. So next we have to move on to find out the level of occlusion in RCA or LCX. So what you can see is when the proximal RCA is involved, you have an involvement of the RV also. Now RV is the most anterior structure in the chest. So since RV is involved, it will have a vector which is moving anteriorly towards the chest leads. In addition, the inferior wall is gone, inferoseptal and inferior wall is gone. Therefore, you will have an ST elevation in 2, 3 and AVF as the injury vector is directed downwards and rightwards and anteriorly, so you will have an ST elevation in V1. Once you see an ST elevation in V1 along with ST depression, ST elevations in 2, 3 and AVF, you should always take right-sided leads because that will help in identifying a right ventricular infarction. If you have an occlusion distal to the origin of RV branch, your RV is not involved anymore. So your vector is not going to come anteriorly. It is going to go inferiorly and downwards only. So you would not have elevation in, yes?
Sorry to interrupt. Can you go on slide mode, sir? Slideshow mode? It will be better.
Yeah, actually it is getting obstructed sometimes. It's not stopping there. Okay, yeah, go ahead. So, yeah. So here what you can see is you would not have ST elevation in V1, V2. You would have ST elevations only in inferior leads but the V1, V2 may actually show ST depressions in these cases. If you have a proximal LCX occlusion, this has gone haywire somewhere, but anyways, here what you can see is you have a intralateral, posterior and inferior segment which is involved, and therefore the injury vector actually is directed backwards and somewhat to the left. So you have ST depressions, ST elevations in 2, 3 and AVF, with lead 2 ST elevation being more than lead 3, and you can have ST elevation in the lateral leads with significant ST depression in V1 to V3. Now, this is a non-dominant LCX. If you have a dominant LCX, what happens is, I'm sorry for this, but something is going wrong here. Okay, so what you can see here is now the inferior septum is also involved, and therefore, in these cases, the vector is moving more downwards away from AVL, and you will have an ST depression in AVL. And the ST elevations in V5, V6 will be more prominent as compared to when you have it in a non-dominant LCX. Okay, so since we are done with both RC and LCX, when should we suspect an RVMI? This is important because this helps us in identifying proximal RC occlusion also. If the magnitude of ST elevation in V1 exceeds the magnitude of ST elevation in V2, or the V1 is isoelectric or showing dubious ST elevation in V1, but there is a significant ST segment depression in V2, then this is highly specific for RVMI, in which we should always take right-sided leads. As you can see here, there is an ST elevation in lead 3 which is more than lead 2. There is more or less mild ST elevation in V1 but significant ST depression in V2. So this is pathognomonic of a right-sided infarction, RVMI. You should always take right-sided leads, and that will change the diagnosis for you. So this is what we look at as the right-sided leads. Most commonly we take the V4R lead, which is 88% sensitive and 78% specific with a diagnostic accuracy of 80%. But what is important is it is a transient phenomena. If you do not do an ECG immediately on presentation, this sign vanishes by 10 hours in more than 50% of the patients. So it is very, very important in a patient with inferior wall MI. You should, if you are suspecting RVMI, take the ECG at presentation itself. V4R lead is very important because it helps in diagnosing RVMI. It differentiates between the RCA and LCX occlusion, and it also helps in differentiating between proximal and distal RCA. As you can clearly see here, if you have an ST elevation and upright P, it is proximal RCA. If you have a no ST elevation with upright P, it is distal RCA occlusion. And if it is ST depression or T inversion, you are dealing with an LCX occlusion. Now, this is which I feel is very important because you can have ST elevation in 2, 3 and AVA both with RC occlusion or LED occlusion, as I have already shown it to you. So if you have ST elevation in inferior leads and you also have ST elevation in anterior leads, which artery is involved? There you should look at V1 lead ST elevation and see if V1 ST elevation is more than V2, V3, V4. That means if your ST segment elevation is progressively decreasing from V1 to V4, then you are dealing with an RC occlusion and the patient has an RVMI. If you have an ST elevation in V1 which is less than V2, V3, V4 and the ST elevations are progressing from V2 to V4, you are dealing with an LED occlusion, and definitely it would be a distal LED occlusion because there is an ST elevation in 2, 3 and AVF. So this is something which helps in linking the diagnosis in some ECGs as this one. You have ST depressions in 2, 3, elevations in 2, 3 and AVF, ST depression in 1 and AVL, so you will definitely think about RC occlusion here. But you also have anterior lead ST elevations, but what you can see is ST elevation in V1 is more than V2, V3. So we are actually dealing with an inferior wall MI with RVMI, and this patient has an RC occlusion. So let us look at some of the algorithms for inferior wall MI localization. If you have ST elevation 2, 3 and AVF, the step 1 is to look at lead 1. If you have ST elevation in lead 1 more than 0.5, you are dealing with LCX. If you have ST depression in lead 1, then you are dealing with RCA. If you have isoelectric ST or ST is less than 0.5, then you have to look at leads 2 and 3, which is step 2. If lead 2 ST elevation is more than lead 3, the direction is towards the left side. That means LCX is involved. So LCX is the culprit artery. If you have ST elevations in lead 3 more than lead 2, then you are dealing with an RCA, but then you have to look at the sum of ST depressions in V1 to V3 divided by sum of ST elevations in 2, 3 and AVF. If it is more than 1, that means ST depressions in V1 to V3 are more than the ST elevations in the inferior leads. You are dealing with LCX, otherwise you are dealing with RCA. Subsequently, proximal and distal RCA can be looked at based on V4R or ST elevation in lead V1. Similar thing has been shown, but here they have already seen the V4R first, and if you have a V4R ST elevation, it is straight away proximal RCA fusion. If not, then rest of the steps are practically the same that we have already discussed. Here they have simplified it a little. ST elevation in inferior leads with ST segment depression in 1 AVL, you are dealing with RCA. Clear? If you have that with V4R or V1 ST elevation, you are dealing with proximal RCA. Done. If this is not there and you have ST segment elevations in 1 AVL and V5, V6, or significant ST depressions in V1 to V3, you are dealing with depth circumflex artery. So this is much simplified as compared to the previous two. All you need to do is look at inferior leads, ST elevation. Look at lead 1 and AVL, ST depression, RCA. Look at V1, V4R. You are dealing with proximal RCA or distal RCA, you can make a diagnosis. LCX, you are dealing with an ST elevation in 1 and AVL. Same thing, but a little different. ST depressions more than 0.1 millivolt in 1 and AVL, you are dealing with RCA. ST elevation in V6, you are dealing with LCX. If you have an ST depression in V3 divided by ST elevation in lead 3, which is more than 1.2, that means ST depressions are more, you are dealing with LCX. Based on just the V4R lead, you can make a diagnosis whether you are dealing with RCA proximal, RCA distal, or LCX. Now a word about posterior myocardial infarction. This is not very common, less common isolated, but it can be seen in an association with inferior or lateral infarctions. And this leads to a much larger area of myocardial damage, and we have higher chances of LV dysfunction, mitral regurgitation, and death in these kind of patients. What you see in ECG, you see horizontal ST depression, tall, broad R-waves in lead V1, and the RS ratio is usually more than 1 in V2. You can have presence of ST elevations and QS in the posterior leads, that means V7 to V9, which we will be showing you shortly. If you do a mirror image of this ECG, then you would actually look at, you would be looking at anterior wall kind of STP changes that you normally see in an LED occlusion. V7, V8, V9 are at the posterior axillary line, tip of the scapula and the paraspinal area. And these are something which help us in diagnosing posterior ulna. Here what we can see is we have an ST elevation into more than 3, RS ratio is more than 1, there is kind of mirror image changes, and ST elevation in V6. When you see this, you should always do a posterior lead, and here you can see there is an ST elevation in V5, V7, V8, V9, which diagnoses posterior ulna. Lateral ulna, this is even less common and compared because of occlusion of V1 wherever that is marginal or radical familiar, which is usually the early V1 or early V1, which is actually around like that microagulation and LVP. So again here what we have to look at is if you are dealing with V1 occlusion, you will have something that will get leftward, clearly and lateral. You will have an elevation 1 AVL with an education and variability. You can have a elevation V5 also. But if you have a forearm occlusion, you would have an elevation in Q3 and AVL, and therefore sometimes you might not be anything that is done. So you should just see an elevation in one AVL and V5, V6, and rest of them are looking normal. Then you should look at in theory if there is an ST elevation in Q3 and AVF, you're dealing with OM most likely, and if there is a depression, dealing with a D1. Okay. So there is a special mention. I felt this is important, although this is not ST elevation, but this is very important because it points to a high-grade stenosis of proximal LAD. So 75% of these people, if left untreated, will develop full-blown anterior wall MI within a week. So this is very important. If this kind of an ECG presentation comes to you, you should always be taken up for intervention. Diagnostic criteria is progressive symmetrical deep T-wave inversions in lead V2 and V3. Discrete or no ST elevation is seen, and there can be a minimal or no cardiac marker elevation in these patients. What is important is there is no loss of precordial R waves, and that basically shows that you are dealing with a viable myocardium, non-infarct myocardium. There are two types, type A, type B. Type A is more common, is associated with diffuse, deeply inverted T waves in V2 and V3. Type B is less common, but it shows a biphasic T wave in V2 and V3, and this is something which actually is because of a lesion between the first and second septal branches of LAD. So with this, I am actually done with the ECGs that localization of MI. So, Sudhakar, we can possibly go ahead and do some practice ECGs in them.
Yes, sir. We'll start the poll. Next 4 questions are for poll. So, sir will put the ECG, and then you can have a look, and then we'll start the polling. So, we'll start, sir, first.
Okay. So, the first ECG is there. This was the first ECG which was in my first lead, or my first slide. So I was thinking you would be able to answer which artery is involved here.
Yeah, so the ECG is flashing, yeah, and I'll put the poll. So I'll start the poll now. Sir, question, yeah, first, yeah. I'll open the poll. Some annotation is coming in between.
What is the annotation?
Deepak, can that annotation go, that mark box? Yeah.
Okay. Okay, this is telling you the answer already.
Fifteen seconds remaining.
Yeah. So I'll just see the reply. Yeah. So most of
the people think
answer B, sir.
Distal LAD. Okay.
Distal LAD.
Correct. So we have a pretty well-read audience here. Good. So you're right. Here, what you can see is there is an ST elevation in leads V2, V3, and V4, which is more than the ST elevation in V1. There is ST elevation in 2, 3, and AVF, and ST depression in AVL and 1. So this can be seen actually in RC occlusion also. But the anterior leads where you have more ST elevation in V2 versus V1 is actually clinching the diagnosis, and we're dealing with an LAD occlusion. Good. So second. You can start the
So
poll, Kakan.
I'll start the poll, sir. Yeah. Poll 5. Yeah.
Okay. I don't know why the slides are moving on its own. Are we doing with the poll?
Yeah,
It's
going
going
on.
on, sir. It's going on.
100 people have answered already. $20 remaining. Yeah, that.
Yeah, I'll show the poll result. Yeah. So the majority have gone with B, RCA.
RCA occlusion. Well, this I have not discussed during my presentation. So what you can see is this is an LBBB morphology. So in the presence of LBBB, you have to look at Barbosa criteria, which was described even by Dr. Bharat. So Barbosa criteria actually says if you have a concordant ST elevation in leads which have positive QRS, then you have five points to it. But if you have concordant ST depression, then you have 3 points to it, and discordant ST elevation more than 5 millimeter, you have 2 points to it. So what you can see here is actually you have a concordant ST depression in V2, V3, V4, and discordant ST depressions of more than 5 millimeter in V5, V6. So this Barbosa criteria is for LAD only. This could just be a manifestation of a wraparound LAD, which is leading to ST elevations in inferior leads. So this Barbosa criteria actually is important in LBBB with MI, and any score more than 3 tells you that you are dealing with an MI. So here the answer would be LAD. Okay, so next ECG. You start the
third ECG. Yeah. So I'll start the poll, sir. Yes, the poll is started.
We have started getting responses. So 150 plus people who are answered already. 10 more seconds to go.
Yeah.
They're done.
So
Good.
we have majority of the answers as B left means.
Very good. Very good. So the answer is correct. You can clearly see you have an ST elevation in AVR more than ST elevation in lead 1, V1, sorry. and ST depression in all other leads. Very ominous sign you're dealing with left main. This is the last ECG.
Yeah. So I'll start the poll. Yeah, poll started.
Yes. We started getting responses. Twenty seconds more. We have got 130 replies. 10 more seconds left over.
Yeah.
Yes, done.
So we got the maximum reply of option A, sir, proximal RCA.
Very good. Very good. So except the thing that I did not talk about, all the answers have been correctly given by all our attendees. Yeah, so you're right. There is an ST elevation in lead 3, which is more than lead 2, and the ST depressions in 1 and AVL. And look at the rhythm. You have no P waves there. So you're dealing with a conduction abnormality. Clearly, it is a proximal RCA occlusion. Very good. Thank you.
We have a question, sir, if you can answer, just will take 2 minutes, sir. Does D winter sign has a localization value?
Yes, it has. It has. I possibly missed that because I only dealt with valence. So if you have a D winter sign, that also is an indicator of a proximal LAD occlusion.
Okay. Okay, sir. I think after a lucid talk, I don't think so many had doubt on this session. So it was very well understood by most of the students. And we have actually one more question, sir. In unstable angina and NSME, can ECG help to localize?
No, the ST depressions usually would not be, able to localize exactly where the lesion is. As you can know from TMT, the ST depressions are not localizing. Okay, but if you have ST elevations, that is usually localizing to the artery of occlusion.
Okay. I think that's. There is one more question. Are there any ECG features of S1 block, only septal block? I think sir has covered this.
Yeah, I had actually shown that. I'll show you again.
That is, I think,
when
something
you have
very.
only septal occlusion, then what happens is your basal septal area is involved. So your vector actually is moving towards V1. So you will have an ST elevation in V1, V2, possible ST elevation in AVR, but you would have significant ST depressions in inferior lead.
Yeah. I think that's all, sir. I think we'll conclude, sir. I think it was an exhaustive session, both the session. And I think I conclude. I would like to thank both our speakers, Dr. Bharat and Dr. Nitin Kansal, who took out their time on weekday and are ready to deliver the session for our residents in cardiology, medicine, and many other students. Thank you again, sir.
Thank you, Sudhakar.
Thank you, Dr. Nitin. On behalf of Medtronic, I would like to thank you. It was a very valuable presentation and well explained, and you were very calm and composed during presentation. It was very well. Attendees could follow it very well. Thank you. Thanks a lot.
Thank you so much.
Thank you, sir.